Hey, I'm Stephanie.
And I'm Alex, and we'll be talking about postpartum blues, depression, and psychosis.
Starting with the blues, you'll know that up to 60% of women will experience mild depression or baby blues. The functioning of the mom will not be impaired, and it is important that you offer anticipatory guidance, make referrals for therapeutic interventions. Moving on to depression.
So, with depression is experienced by 10 to 15% of postpartum women. And with depression, it can incapacitate them to the point of being unable to care for themselves or their babies. With depression, the cause can be biologic, psychologic, situational, or multifactorial. But 20 to 30% have a previous psychiatric disorder, such as general anxiety or previous depression. Another cause can be the estrogen fluctuation. So, like mentioned in class, while you're pregnant, you have like 90 birth control pills of estrogen stored in your body, and postpartum, it just completely drops out. So, you can imagine how down in the dumps mom could feel. Another risk factor for postpartum depression is personal history of, like I said before, personal history of depression, general anxiety disorder, a lack of a confiding relationship, so nobody to talk to, younger moms, moms with low education, African American moms, moms that receive Medicaid or need financial support, and then also if a mom had maybe an unplanned pregnancy or it's a very stressful pregnancy. Postpartum depression is more serious and persistent than baby blues. Mom may be feeling guilty and inadequate, being an incompetent or inadequate parent. An important screening question for postpartum blues is determining if they have a problem falling asleep, because oftentimes they're very irritable. They might have violent outbursts or uncontrollable sobbing. And a lot of times the outbursts are directed against other people, like, my husband never helps me with the baby, or the baby cries all the time, so I just feel like hitting her. They usually feel guilty about having these feelings when they think they should be happy after having a baby. And one final thing is medical management. So supportive treatment is very effective, but it's not usually the only treatment option for these moms. For pharmacologic intervention, they can take antidepressants, anti-anxiety agents, mood stabilizers, and they're encouraged to just kind of take time for themselves, rest, relax, and maybe go to some support groups or marital counseling.
Moving on to psychosis. This is rare. 0.1 to 0.2% of moms experience it, and it's 30 to 50% more likely to recur if the mom has had it already once. Onset occurs at 2 weeks postpartum. In this, you'll see that the mom is having auditory or visual hallucinations, delirium and disorientation, extreme deficits in judgment, impulsivity, and increased risk for suicide or infanticide. The mom will be experiencing fatigue, insomnia, restlessness, tearfulness, emotional lability, inability to move, stand, or work, and the mom will also be having some of the suspiciousness, incoherence, and obsessive concerns. What we look for is these delusions and hallucinations may be what's causing the mom to start to think that she either needs to kill herself or kill the baby. That's why it's extremely important that there be constant supervision when the mom is with the baby or giving care to the baby, because it is a psychiatric emergency. The mom will need early detection, aggressive treatment, and good prognosis. Antipsychotics, mood stabilizers, lithium, and psychiatric hospitalization is all needed.